Hey guys, this is Charles Clinton, Chapter 20, Summary, Coronary Angiography and Intravascular Imaging, 11th edition and latest for Braunwald's heart disease. So this is my disclaimer. You can pause the video and read it through. And now we're talking about acute adverse reactions after injection of intravascular iodinated contrast agents. So let's focus on the table. You have, in general, allergic reactions and physiologic reactions. The allergic reactions are what you would think of with immune-mediated hypersensitivity. You would think of itching to skin rash to local edema to full-blown anaphylactoid reactions, and you grade this with from mild to moderate to severe. Of course, if the patient is hypoxic or in anaphylactic shock or in extreme edema, this is a severe reaction. Why did I cross out the like in allergic like? Because that is not allergic like. That is called allergic reaction. While physiologic adverse reactions are also known as allergic-like. Why is this? Because they seem as allergic, but they are not hypersensitivity mediated. There is no hypersensitivity in this. This is physiologic reaction where you can see different manifestations. You will grade from mild to severe. What will you see here? Hypertension, nausea and vomiting, vasovagal symptoms or signs, angina, arrhythmias, and convulsions. Remember that the main risk factor for adverse reaction to contrast agents is having one of these previously. Recurrence is 50%, and the adverse reactions may be acute or delayed. Acute adverse reactions go from seconds to minutes of injection, and in patients with down below with a history of anaphylactic reaction, you have to pre-medicate this patient. Remember, there's no absolute contraindications to catheterization. There are only relative contraindications. So what will you use? Hopefully at least 12 hours before cath lab and 1 hour before cath lab, you will use different medications as anti-H2 blockers like cimetidine, anti-H1 like diphenhydramine, and steroids. Remember, there's different protocols, so use the one you like the best, and they are described below, all those red lines down below. So, delayed adverse reactions. They are mainly are the most frequent delayed adverse reactions are the dermatologic, in the dermatologic field. So probably not life-threatening, most of them. Urticaria, rash, angioedema, and pruritus. While the rare delayed adverse reactions may be life-threatening. Delayed means more than 30 minutes up to 1 week after injecting contrast. What are the angiographic projections? Now we'll talk about this. And before going into this, well, I'll explain what we see in this slide, and then we'll go out of Braunwald's book and into a nice website. Let's see. First, the PA view. But before looking at the views, look at the image down below. There you can see the arc, and the arc has a lower portion and what is above the patient. What is below the patient is the X-ray tube. Here is where the X-rays are emitted. Above the patient is the image intensifier, where the X-rays will be received. If the image intensifier, wherever the image intensifier is located according to the patient, that is the angulation we will give this angiographic projection. So this is what gives us the angulation. If the image intensifier is right straight in the patient, crossing the patient in the middle, it's called a AP view, which actually technically should be called a PA view since the X-ray crosses the patient from behind. If the image intensifier is on the right, it's an RAO, right anterior oblique. If it's on the left of the patient, it's a LAO, left anterior oblique. If it's cranially, it's cranial. If it's caudal towards the feet of the patient, it's caudal. And this is the page I'm talking to you about, Angiographic Projections Made Simple, an easy guide to understanding oblique views. So we'll use this, which was done by Morton Kern. It's available on the internet for free. So I got some pictures out of this webpage, and this is the nomenclature. We already talked about the AP position, the RAO position, LAO, cranial, caudal, and we already know this. If you want, you can pause the video. And here is the illustration showing the different projections, so you remember them or you associate them with these pictures. Here we can see the explanation of how you can understand the different angiographic projections. So clench your fist with your right fist on your thorax. You just clench your fist, that would be an AP view. And if you want to see the left ventricle, so extend your fingers, and that's how it looks. In C, how can you differentiate LAO from RAO? Left anterior oblique, so see a patient or place someone in front of you, or imagine yourself with your left shoulder anteriorly. That is LAO. And your hand, your heart, will be practically right in front of you. That is why there's some foreshortening of the length of the left ventricle, and you can see the heart as rounded. If you do a RAO view, then you can see the heart straight out. It's like seeing the heart laterally. And on the right, you can see the heart shape with how it would look as a figure. This would help you understand the disposition of the heart and what you are seeing. On this next image, we're saying the same. In AP, you can see there's no shoulder protrusion. In LAO, shoulder protruding is the left one. So you see the heart as a circle. In the RAO, the right shoulder is protruding, so you can see it as a cone, for example, as a cone, and not that circular. Here you can see ventriculography, and here contrast material is injected in the heart, and all the left ventricle is painted with contrast material. So you can see how LAO, the heart is circular, and RAO on the left, on the right side of the image is, you can see almost all the left ventricle expanded as a cone-like figure. So in the LAO, you can see the septum, which would be number 4, and in RAO, you'd see no septum. On the right, you see anterior, mainly anterior and inferior walls. And on the left, in the LAO, you see mainly a septum, lateral, and apex. This is a way you can close your right hand, and with your left hand, you can make this disposition. With the color coding, you can see that green stands for left main, purple for right coronary, right LAD, and red would be LAD, and yellow circumflex. In this view, you are seeing probably, and this would be top left fingers. Let's see, LAD, we already saw that. The posterior descending will be shown below. Top right, the coronary arteries are shown with the heart or fist removed in the anterior posterior projection. The green block represents left main, yeah. So this is an anterior AP view. That is why you can see the man on the picture without any protrusion or any shoulder in front of him. So this would be the common AP view. Then you can see the LAO. This is for the left coronary artery. In the LAO, in the cranial position, it's like doing a peace sign, but in a patient that is kind of old, without any strength. That's why the hand is going down. And the LAO in the caudal position, it's a strong peace sign. So peace sign for LAO for the left coronary. Cranial is someone without strength, right? And caudal is with strength, okay? Then, if you think, I'm gonna associate this with thinking with the head. If you think with your brain, cranial brain, probably you will be able to control what's down below, so it points down below. If you think with what is caudal, and by caudal I mean what you're thinking about, so if you think with that inferior thing, it will be going up. That's why the peace sign would be peace sign will be going up. So here is the same projection with reconstruction of CT scanning. For the right, now we're seeing the left coronary with the RAO disposition. Here you could, it's like the same peace sign, but it's a little rotated. And then use your same peace sign with the fingers pointing to the front, but now rotate it in a clockwise. Rotate your left hand in a counterclockwise manner. Let's see, in a counterclockwise manner, and this will help you with the RAO with caudal and cranial. Caudal is your hand going down, and cranial is your hand going up. This makes sense using the analogy I just used, which is not, it's much more simple to point your hand down if it's caudal, and point your hand in a more cranial position if it's cranial. Makes sense, right? This is the reconstruction for RAO projection for the left coronary artery. Now for the right coronary artery, what you see in the morado purple color is the posterior descending. So look at this guy in the LAO. LAO, I associate for the right coronary. It's something that usually makes sense. For LAO, the right coronary will see, you will see the right coronary as a C. For RAO, the right coronary looks like an L. When we see the angiography projections, you'll see it makes sense. Right coronary LAO looks like a C, RAO looks like an L. Or if not, use this finger pointing straight forward. For this would be the posterior descending, or pointing forward but with looking like to the left. This would be the LAO. Remember that your right shoulder would be anteriorly projected. So here is what I was saying. On the left you can see the LAO looks like a C, and on the right, the right RAO looks like an L. And there you can see the different way the posterior descending is oriented. And that is all for that parenthesis, so we understand better the angiographic projections. In the next section we continue with the book.